last session in the conference. ACL reconstruction is extra-articular tenodesis versus isolated ACL reconstruction, a randomized controlled study by Dr. Hesham Gawish.
Thank you, Chairman. I will give a randomized controlled trial about ACL reconstruction with extra-articular tenodesis versus isolated ACL reconstruction in patients with high-grade anterolateral rotatory instability. First, the ACL has two main bundles, the anteromedial bundle, which is the main responsible for anteroposterior stability, and the posterolateral bundle, which is responsible for the rotational stability. The current problem with the ACL reconstruction techniques we have that most of the cases have a very good anteroposterior stability. However, about 25% of cases still have residual anterolateral rotatory instability, which we call mini pivots. These mini pivots are responsible for failure of ACL graft, meniscal injuries, and progressive cartilage loss, and the premature osteoarthritis, and the failure to catch the pre-injury level of sports activity. So the solution is to add something lateral to the intra-articular reconstruction. And they found that a laterally based graft will have a better and more larger lever arm to control the rotation than a central graft. And Ellison found it is easier to control the rotation of a wheel from its rim, not from its hub. And obviously, with the cases of ACL tear, we have found many cases with anterolateral injury, which we call second fracture. And in the MRI, more commonly, we found bone marrow bruises in the distal femur and the posterolateral tibial plateau. So what is the anterolateral lesion or the lateral lesion present? There is a many debate about the structure which is responsible for this injury since both Sigmund in 1979 till Vincent and Claus who call it anterolateral ligament. We have two main schools. The first school says that the distal iliotibial band fiber is responsible for the pivot restraint, and the other school called the anterolateral ligament is the main responsible for this. The distal iliotibial band fibers are composed of three main structures, that proximal capillin and distal capillin and the capsuloosseous layer, which is the main layer responsible for constraining of the pivot shift. It has a different anatomy than the anterolateral ligament. It is present deep to the lateral collateral ligament, and it is just above the capsule, inserted into the lateral tubercle of Terry, which is midway between the girdle and the fibular head. The anterolateral ligament has the same insertion in the tibia, but has a different femoral insertion. It is debated in the literature, it is proximal and posterior or distal and anterior to the lateral epicondyle. However, it is superficial to the lateral collateral ligament and tight with flexion. So which one is the main constraint of the pivot shift? We have multiple biomechanical studies. First is tensile probability studies that found that the distal capillin and the proximal capillin fiber are the strongest structures present in the anterolateral corner of the knee, and the anterolateral ligament is very weak to constrain the pivot shift. Also, we have internal rotation restraint. Kittel et al. Did a study, found that the distal iliotibial band fiber is the primary strain to the internal rotation between 15 and 30 or to 90 degrees of flexion. This is the position of pivot shift. And the ACL only act at 0 degrees, and the ACL and the anterolateral ligament act only after 40 degrees of flexion with deep flexion and have a very minor rule. And even the MCL and the posteromedial corner have more important control for the internal rotation than the anterolateral ligament. Also, the length changes. They found that the anterolateral ligament is not isometric, it's tight in flexion, and the extra-articular tenodesis procedures are more isometric. So it is more logic to reconstruct the capillin fiber and the capsuloosseous layers. So for the treatment of anterolateral rotatory instability, we have a double bundle reconstruction of ACL, we have extra-articular tenodesis, and we have anterolateral ligament reconstruction. We believe in extra-articular tenodesis, so we did a randomized controlled trial to compare ACL with extra-articular tenodesis versus ACL reconstruction alone in patients with grade 2 or 3 pivot shift under anesthesia. It was a prospective randomized controlled trial done in Alexandria University. All patients were male. Patients were randomized using computer-generated randomization list. There was no blindings due to different incisions, and patient recruitment started since January 2017. Patients were divided into two main groups. The group A for ACL reconstruction, 35 patients, and the group 2, we did ACL with Lomer, modified Lomer operation, and we were also 35 patients. No patient lost follow-up, and the follow-up was done for 12 months. In both groups, we did ACL reconstruction. We did anatomical single bundle ACL reconstruction through accessory anteromedial portal using CMT and gracilis. The least accepted graft was 9 millimeters. We used a suspensory femoral fixation and the biointerference screw for the tibia. Regarding modified Nour operation, we did an oblique skin incision. We take a strip of the iliotibial band, lift it, attach it distally, and we stitch the proximal end. And we tunnel the graft under the lateral collateral ligament. And we fix the graft in neutral rotation with 30-degree flexion with minimal tension. Patients were assessed for primary outcome is improvement in the patient-reported outcome, Sholem and IKDC. And the secondary outcome were objective assessment with using the IKDC and the KLT for instrumental anteroposterior instability, rotational instability, and the quadriceps function. Pain was assessed using a VAS score. Quality of life was assessed using a general health quality of life score and the limb-specific quality of life score and the ACL quality of life score. Activity of level was assessed using a Tegner and the Marcus activity scale. Return to sport was assessed by return to sport injury scale and the Tampa scale of kinesiophobia. The mean age of the patient was 27 years. All cases were male. The right side was affected more, and all cases have non-contact ACL injury. They were all Tegner 7 recreational athletes. No one of our cases were a competitive athlete. Pivot shift was present in 60% of group A had pivot grade 2 and 70% of group B had pivot grade 3. The mean Sholem score was comparable in both groups pre-operatively. Regarding the patient-reported outcome, we found no statistically significant difference between the two groups regarding the Sholem and the IKDC. Group B has 4 outliers with poor results. They had 4 arthrofibrosis, residual flexion deformity, and severe quadriceps wasting at the end of the follow-up. Regarding the objective assessment, Group B outperforms the Group A in the form of IKDC, quadriceps function, instrumented anteroposterior laxity, and rotational laxity. Regarding quality of life, Group A has better quality of life than extra-articular tenodesis group, but no difference in the limb-specific quality of life and ACL quality of life scores. The pain was found more in extra-articular tenodesis group for 6 months. The pain was most common in the tenodesis side, maybe due to over-tightening of the iliotibial band to close the defect, and the pain totally subsided after 6 months. Regarding return to sport, there was no difference between the two groups, and regarding the activity post-operative, no difference between the two groups. For the complication, we have 3 main complications linked to the extra-articular tenodesis group: post-operative stiffness and flexion deformity and graft site infection. We have 1 case of re-rupture of the graft. It was happened in Group A, and it was a traumatic case. We compared our results to the literature. We found our results comparable to the literature. Also, the pain and the complication were found to be more with extra-articular tenodesis group. This is a stability study. This is the largest study done on the same topic we have. It was a level 1 evidence published in 2020. It's a prospective multi-center randomized controlled trial. EGAA sponsored in 7 centers, 600 patients. They did also modified Nour, but fixed it with a stable and 70 degrees of flexion. They found that the addition of extra-articular tenodesis lead to less graft rupture, less meniscal tears, and more complications and more pain. And the patients at the end have the same patient-reported outcome and the same return to sport, the same quality of life, and the same range of motion. The limitation of our studies: there was no blinding due to different incisions. There was no uniform implant designs. In some cases, we used a closed loop and in the others, adjustable loops. The short follow-up was not enough to assess meniscal injury and the graft rupture and the osteoarthritis. The lack of instrumented rotational and anteroposterior assessment. None of the patients was a competitive elite athlete. Some scores were in English scores with no Arabic validation, and there is no different meniscal and chondral procedures were done. Our conclusion that ACL with extra-articular tenodesis outperform isolated ACL reconstruction with better neuromuscular control. They have better anteroposterior stability, better rotational stability, and better quadriceps function. However, the better stability was not translated into better functional scores or return to sport or quality of life in recreational athletes. And we have to consider the complication of this procedure when offering this procedure as a solution for anterolateral rotatory instability in non-competitive needs. Thank you.
Thank you, Dr. Hesham. Thank you, Dr. Hesham, for this very nice talk. Now with the next talk, with the next speaker, Dr. Asem Nouruddin. talking about combined anatomic ACL reconstruction with hamstring tendon and extra-articular tenodesis using luteal band through a single femoral tunnel and single femoral fixation.
Bismillahir Rahmanir Rahim. Thank you, Mr. Chairman. And I'd like to thank all the EGAA committee members for giving me this chance. My talk is about concomitant ACL reconstruction and extra-articular
الصوت يا دكتور
tenodesis.
عاصم الصوت.
Concomitant ACL reconstruction with extra-articular IT band tenodesis through a single femoral tunnel and with a single femoral fixation. Historically, before the advent of arthroscopy, ACL deficient knees were managed with extra-articular lateral reconstruction. Several techniques have been described, but with high failure rate because these techniques was performed without concomitant intra-articular reconstruction, with the joint being secured in a subluxed position, non-anatomic reconstruction, and prolonged post-operative immobilization. Focus then was directed toward intra-articular ACL reconstruction. Results are satisfactory, but the patients with complete ACL injury have different degrees of rotational laxity. Residual pivot shift has been found to be positive in more than 15% of cases after an accurate ACL reconstruction. Double bundle ACL reconstruction developed to control this rotational instability. Results were similar to single bundle ACL reconstruction, but with double cost and double time. Lateral extra-articular tenodesis is peripheral to the center of rotation of the knee and provides a better lever arm in controlling tibial internal rotation than isolated intra-articular ACL reconstruction. Prospective study was carried over 36 patients with complete ACL tears in Minya University Sports Unit from Jan 2018 till Jan 2019. All cases underwent concomitant ACL reconstruction and IT band tenodesis. Patients were evaluated by IKDC score. We had excellent results in 30 patients, good in 4 patients, and 2 patients didn't complete their follow-up. Indications for a combined procedure include one or more of the following criteria: grade 3 pivot shift, chronic ACL lesion, ACL revision, high level of sporting activity and pivoting sports, associated C-joint fracture, and lateral femoral notch sign on radiographs. This is a demonstration of our technique. This is a grade 3 pivot shift, positive Lachman and anterior drawer test. We take the hamstring gracilis and CMT and treble them into 6 strands graft over a U-loop. So we have 6 strands graft with a minimal diameter of 9 millimeters. Then we arthroscopically define the anatomic femoral attachment of the ACL. We mark it. Then we put the tibial guide pin into the tibial ACL footprint. After that, we make a long incision, about 6 centimeter incision at the lateral femoral epicondyle. Then we identify the IT band, and we take a band of the IT band of about 1 to 1.5 centimeter wide. Then we carefully release it proximally. And then we release it distally until we identify the lateral collateral ligament. The IT band is tubularized with Vicryl number 2. Then we pass it under deep to the lateral collateral ligament. With a diathermy, we mark the site for the femoral tunnel, which is proximal and posterior to the lateral femoral epicondyle. We put a femoral guide pin from outside. Then we make the femoral tunnel from outside while we protect the PCL with accurate. The soft tissues and bone debris are removed from the tunnel. Then we pass 2 wire loops from outside, one to be retrieved from the anteromedial portal, while the other one will be retrieved through the tibial tunnel. Then we make the tibial tunnel. Then we pass the ACL graft, and then we reverse the loop in the anteromedial portal to shuttle the IT band into the same femoral tunnel from outside in. This is another patient showing the 2 grafts into the tunnel. We cycle the knee, and then we put 1 screw into the femoral tunnel while the knee in about 20 degrees of flexion or near extension. Then we cut the visceral sutures of the IT band from inside the knee. We check the ACL. Knee is examined. It is stable. This is 1 year follow-up of the same patient. Full range of motion, flexion, extension. His knee hyperextends normally. So we take home message that concomitant ACL reconstruction with IT band tenodesis is a very useful method to control both anterior and rotational laxity. Our technique is cost effective and has less morbidity on the patients. Select your patients. Longer time for follow-up studies are still needed. Thank you.
Thank you, Dr. Asem. We will go to the third talk by Dr. Mohamed Al-Nahas for high tibial osteotomy combined with ACL reconstruction.
Dr. Asem.
Your femoral tunnel was outside in, okay, and you use inside you have the anatomical point, and outside in the area you choose to put the graft of Lumiere technique, and you pass the 2 grafts from the shape.
I can localize the anatomic point of
You
the
have 1
outside.
graft to be pulled inside the tunnel, and 1 graft to be pulled outside. Does it affect the tension of the ACL graft?
No, it doesn't affect the tension of the ACL graft. We cycle the knee, and then we fix both grafts at the same time. It doesn't affect the tension. According to the size of the graft. Really, yeah. really, I size the hamstring. It's about 9 millimeter. Then I make a 10 millimeter femoral tunnel. To accommodate both grafts.
What about the length of the tunnel? I think it's a very short tunnel because you enter from the lateral aspect, not the posterolateral one. And going inside the knee, I think this tunnel will be a very short tunnel.
I measured it about 3.5 centimeters. Thank you.
Can I ask you a question? Did you report any complications or stiffness with your patients after this procedure?
No complication, but in one patient I found that there is a prominence on the lateral aspect. I thought it was the screw that moved from its side. Then I opened on it, I found the screws in its place, just more ossification. I removed the bone, but no limitation of movement.
And you think sometimes the pivot shift, or the reason we have pivot shift, is because we put the tunnel, all of us, not just you, whatever, that if we did the tunnel in the correct position on the femur, that we would not have a pivot shift and don't need the extra-articular tenodesis. Do you think it may be something with our technique that we are doing that allows for the persistent pivot shift after surgery sometime?
The femoral tunnel is put anatomically.
Right.
We localize
but
it.
Anatomic for you and you and you is different, and me. So
Why?
what do you think that there may be something we are doing with surgery, could be, or just the tissue is stretched out laterally?
I don't know.
Because we know if we put a central tunnel, the patient will have a very big pivot shift, right? 12 o'clock?
It's not,
So
it is not a vertical tunnel, it is a horizontal tunnel.
No. So we know if it's too vertical, it will spin. So do you think we should be putting the tunnel somewhere different, and then we don't need to do extra-articular tenodesis?
I don't know really.
Yeah. Okay, thank you.
Any other question for Dr. Asem?
Dr. Tonino what said that there is a checklist for anatomical ACL reconstruction. Everyone is doing an ACL reconstruction and he's considering his ACL reconstruction to be anatomical. So there is a paper studying what's truly an anatomical ACL reconstruction, and there is checklist that you have to fulfill after you finish your ACL to know that your ACL was really anatomical or not. So in part of location, as you see in arthroscopy and post-operative X-ray and CT, to document that what you did is a really anatomical ACL reconstruction or not. Because I can do an ACL and call it anatomical, and he do another ACL and call it anatomical. So the anatomical ACL has to be consolidated with a criteria defined. If I fulfill this criteria, this is an anatomical ACL. Thank you.
Assalamu alaikum wa rahmatullah. This paper was published in 2019 in Orthopedic and Rheumatology magazine, and this paper was done in Al-Hussein Hospital, Al-Azhar University, about the high tibial osteotomy combined with anterior cruciate ligament reconstruction in patients suffering from ACL deficient varus knee. It is not uncommon for patients with varus knee and the early degeneration of the articular cartilage to develop acute ACL injury with subsequent knee instability and aggravation of the medial compartment symptom of arthritis. And it may also be essential to correct the deformity around the knee joint that may increase the load on one of the knee compartment or stretch the ACL graft. The resulting argument here would be, should the ACL reconstructed in this patient in isolation or as a combined procedure? In this study, combined ACL reconstruction with high tibial osteotomy were performed in patients suffering from deficient ACL and symptomatic varus deformity. Patient and method selection of the patient treated surgically by combined open wedge osteotomy and ACL reconstruction for patient symptomatic varus knee malalignment with symptomatic ACL deficiency with repeated attack of giving way, and exclusion criteria like partial tear في ACL or advanced knee osteoarthritis or non-symptomatic varus knee. Before operation, pre-operative assessment by plane X-ray AB and lateral view to showing the medial compartment, opening of the medial compartment in the AB view, and showing also the osteoarthritic change. Or any other pathological condition, but the lateral X-ray is performed to show the posterior tibial slope, which has an importance in high tibial osteotomy to avoid a change in this posterior tibial slope and to avoid make more stress on the ACL on the sagittal plane. CT scanogram was done to actual deformity, so the degree of the deformity. And this surgical technique, we start the operation by two steps. First step, we do the ACL reconstruction arthroscopic by ordinary method, like make an incisional in the medial line of the SGS to strapping the tendon like this. And this incision, it is the same incision for putting the plate. And this, in this view, we strapping the semitendinosus tendon. After that, we do the femoral tunnel here in this view, and this is the shadow of the tibial tunnel. And we started to make the high tibial osteotomy open wedge, putting this 2K wire 1 centimeter distal to the articular surface to avoid shattering of the two condyle when doing the osteotomy. And this is the guideline K wire, put the osteotomy or the saw to make the site of the osteotomy in the cora from the medial side to the lateral side 1 centimeter from the articular surface, and avoid the head of the fibula to avoid making another fibular osteotomy. We then put the spacer on the opening to open the wedge. After that, we're putting a spacer plate about 10 millimeter to correct the degree of the deformity, and putting the screw like this. And it is the end of the operation, showing the plate and doing the opening for osteotomy site here. And this view showing the site of the tunnel here, which away from the site of the osteotomy, just proximal to the site of the osteotomy. And after make the osteotomy and putting the plate, we tighten the graft by making a biodegradable screw on the tibial tunnel. Case number 1, male patient, 23 years old, complaining from the medial knee joint line pain, was giving way, positive Lachman anterior test on all tests for ACL tear, and also has negative stress virus and valgus test. And this the X-ray pre-operative AB and lateral view. This MRI showing the complete femoral attachment of the ACL detached or tear. And this the scanogram to showing the actual degree of the deformity by measuring the proximal tibial femoral tibial medial angle. And this immediate post-operative view after making ACL reconstruction and do the high tibial osteotomy. I have a point for focus on the tibia, posterior tibial slope here, because this point is very important. Try to consider the triangular geometry of the tibia when we are making the high tibial osteotomy to avoid increasing this posterior tibial slope, which makes over stress on the graft. And this view after 6 months, consolidation of the site of the osteotomy here, and the posterior tibial slope is normal position. And after 1 year follow-up, this second case, male patient 27 years old, complaining from medial knee pain and giving away 2 years ago, positive Lachman anterior test and McMurray test with inverse deformity at the right side, negative stress varus and valgus test. Also, this a pre-operative X-ray to showing the site of the deformity, tibia vara, and this MRI showing a complete tear of the ACL here, and the scanogram to detect the actual degree of the deformity. It is an immediate post-operative operation showing the site of the deformity and the site of the graft. Try to put the plate posteriorly And this another point also to avoid also loss of the posterior tibial slope or increasing it. This view after 6 months ago, and this after 1 year. Combined ACL reconstruction and the high tibial osteotomy become increasingly used for a treatment of ACL deficient varus knee. And ACL reconstruction can restore the anterior instability, and also high tibial osteotomy reduces the load on the medial compartment, preventing or delaying the progression of arthritis of the medial compartment. We correct the deformity to the normal value so that the weight-bearing line pass through the 0.15% of the tibial plateau in patient with double or triple varus, and the aim of this open wedge is also to transfer the axis of the weight-bearing to the center of the knee. Simultaneous procedure is performed over staged procedure, preferred over staged procedure, as it is the short time procedure that doesn't add much time to the total time of the surgery, and safe as it doesn't interfere with the tibial tunnel placement, and at the same time it does not disrupt the post-operative rehabilitation program for ACL. Conclusion: combined ACL reconstruction and the high tibial osteotomy in ACL deficient varus knee is a promising procedure. Thank you.
Thank you, Dr. Mohamed Al-Nahas. Now is Dr. Mohamed Abulsoud talking about high tibial osteotomy and evidence-based approach. Dr. Mohamed Al-Azhar.
Thank you, Chairman. So we're going to speak about the evidence in high tibial osteotomy. As we have a lot of practice, as high tibial osteotomy is a very well popular technique, but we speak about what the evidence support and doesn't support as regards our practice. Okay. So why do you have to study the evidence? Because it's very helpful in our decision making, and it gives us an idea about the prognosis of our proposed surgery, and it's very important for patient counseling, as the patient usually asks a question like, when I will be back to sport, will I be back to sport or not? I will need a replacement after this operation or not? We have to have an answer. So I have nothing to disclose. So in the next 10 minutes, we speak about the evidence in high tibial osteotomy in young adults as regards the patient selection, the preoperative planning, the implant choice, the technique, and survival of the technique. So the outcome of the high tibial osteotomy basically depends on good patient selection and proper preoperative planning and precise surgical technique. So what about the patient selection? We speak about the good prognostic factors, which are the constitutional metaphyseal varus, which measured by measuring the tibial bone varus angle. Measuring the tibial bone varus angle, which is simply you take what is perpendicular to, it doesn't appear here, but we'll show it. But we speak about other points with symptomatic medial compartmental osteoarthritis. There is no. So, constitutional metaphyseal varus, symptomatic medial compartmental osteoarthritis, minor patellofemoral complaints, intact lateral compartment, and less than 10 degrees flexion contraction. On the other hand, we speak about the negative prognostic factors are smoking, valgus malalignment less than 5 degrees after 5. اسف جدا الصور ما طلعتش على البرزنتيشن، فمعلش دقيقه واحده، اسف جدا. لكن احنا بنتكلم على البوزيتيف بروجنوستيك فاكتورز اللي انا بختار بيها العيان، ان انا لازم يكون العيان عنده سيمتوماتيك فيروس وعنده intact lateral compartment with minor patellofemoral complaints. Negative prognostic factor are smoking, malalignment after post-operative 5 weeks, and we speak about the intraoperative or post-operative hinge fracture. Okay, give me a moment. So age is not a major risk factor, and obesity is not a contraindication on high tibial osteotomy, especially when you speak about locked plates. In unicompartmental arthritis with casing lesion, which is called pagoda knee, the high tibial osteotomy gives very comparable result to unicompartmental arthroplasty. Another evidence from American Academy of Orthopedic Surgeon Association guidelines, which speaks that no difference between unicompartmental arthroplasty and high tibial osteotomy in outcome and complication in patients with minor compartment osteoarthritis. So the preoperative planning, what is the evidence in preoperative planning? We find that evaluation of lower limb deformity using tracing paper or even using PACS method, similar inter and intra-observer reliability, so we can depend on both. And there is no difference between different planning software as we have currently more than one, but all of them are valid. We speak about the Miniaci method. Miniaci method gives us very high reliability as regards angle correction and opening distance, because Miniaci method gives us how many millimeters I need to open intraoperatively, does not give you an angle only. And it's more reliable than using simply the cable test during intraoperatively. While another point of measurement which is called PADO method, both are valid and gives intra and inter-reliability, inter-observer reliability, but as I said earlier, that Miniaci method gives you millimeters, not angles. So why we speak about high tibial osteotomy in an arthroscopy conference? Because of this slide, because you need to do an arthroscopy before high tibial osteotomy. Because the arthroscopy verify our indications, may modify preoperative planning, and perform arthroscopic surgery, intraoperative concomitant arthroscopic surgery, which is usually needed. In two studies with a very big sample size, more than 300 patients, we found out that the operation has been rejected due to severe affection of the articular cartilage in 15% of cases, and more than 90% of cases of high tibial osteotomy need an arthroscopic work. That's why we do arthroscopy before high tibial osteotomy. So which plate you should use, locking plate or non-locked plate? Locked plates are superior to non-locked plate as regard correction maintenance, correction loss angle, and clinical outcome. Which method you should use? High tibial osteotomy and high tibial osteotomy, closing wedge or opening wedge. We have this meta-analysis in 2011. So it concluded that no difference in clinical outcome and incidence of complications, but opening wedge high tibial osteotomy increased the risk of greater posterior tibial slope and patella baja. But in taking both points into more focusing, we found that in the impact of high tibial osteotomy and posterior tibial slope, the variation is only 2 millimeters, which is not clinically significant. As regard the patellofemoral, the patella baja, we found this meta-analysis in 2015, speaking about the patellar height decrease only 7%, and after, especially when we used with in Salvati index, and the no change in patellar height with closing wedge. But this is for tibial references. When we measure the same parameters on femoral reference with femoral patellar height index, like this, there are no changes in opening wedge osteotomy. The other point, there is that what's the type graft should be used in opening wedge osteotomy? Let me tell you, you don't need any graft. One of the evidence is present among us was Professor Mohamed Radwan and his work group, and we find the use of bone graft increase 4-fold the risk of complication, and when you use the plate, the use of bone graft does not affect the outcome or reunion rate. However, the autograft has higher reunion rate than allograft, and synthetic bone graft is not recommended at all. When you have a combined procedure, like the last lecture Professor Mohamed Al-Nahas, the combined high tibial osteotomy and ACL reconstruction results in significant improvement on post-operative functional outcome with low rate of complications or re-ruptures. However, it remains unclear if high tibial osteotomy with ACL reconstruction is superior than using high tibial osteotomy alone or ACL reconstruction alone in varus knee. And both techniques does not stop the progression of osteoarthritis. So even if you correct the high table osteotomy with ACL reconstruction, we should consult our patient and should instruct him that will not stop the progression of osteoarthritis. How long the technique should survive? The survival, which simply the typed conversion to total knee arthroplasty. We find this meta-analysis which concluded that 5 years survival is about 95% after 5 years in opening wedge and comparable to closing wedge. However, 10 years survival of closing wedge osteotomy is less than 85%. This is for technique-wise. What about implant-wise? If you speak about using the non-locked plates, we find the 10-year survival is about 75 or 80%, while may reach up to 100% when using locked plates. What about the return to sports after high table osteotomy? We have this meta-analysis which was being published in JBJS 2016 that 87% of patients returned to sport post-operatively and 54% of them returned to competition for sports. It needed 1 year to return to sports. 85% of patients returned to work and 65% to two-thirds of them returned to the same activity of daily living. So the take-home message is, young patient with metaphyseal tibia vara, well-corrected and preserved joint orientation gives best outcome. There is no difference between specific program or planning or using tracing paper in computer imaging and planning for high table osteotomy. Arthroscopy prior to osteotomy may modify planning and allow for therapeutic surgery and concomitant knee pathology. Locked plates, best outcome or survival in the surgery. No significant difference in results between closing wedge and opening wedge high table osteotomy. The 10-year survival rate is about 85 to 90%. Return of activity of daily living about 80% of cases. Thank you very much. I'm very sorry for what happened in the beginning because some technical error. I'm very sorry for this.
Thank you, Dr. Mohamed Abulsoud. Then we will go to the fifth. Okay. تفضل. دكتور محمد أبولسعود. Management of focal chondral lesions in the knee joint by osteochondral autograft transfer system by Dr. Soliman Hassan.
Thanks, Mr. Chairman. I will talk about management of focal chondral lesion in knee joint by osteochondral autograft transfer system. Chondral lesion, on reviewing the literature by Kelly et al. And reviewing more than 30,000 knee arthroscopies, they found that the chondral lesion is more than 60% of knee arthroscopy, and 5% of them are deep defects, grade 3 and 4 in patients under 40 years. So why it is a problem? Because the cartilage is a unique structure, has a limited capacity for regeneration because it is avascular, aneural, alymphatic with a low metabolic activity. Healing of the articular cartilage, superficial laceration does not heal, while the deep laceration deep to the tide mark healed by fibrocartilage. So when we are looking for the surgical treatment, a lot of modalities has been established through the palliative, reparative, and restorative technique. So the idea of the OTS is to recreate a hyaline cartilage, reproducing a zonal architecture and integrating with the surrounding tissue with a durable, cost-effective, single-stage, minimally invasive procedure by harvesting a viable, structurally intact cartilage with the bone plug from a least loaded portion of the knee joint and transplanting it to asymptomatic cartilage injury. Our aim of the work is to evaluate the functional outcome of the treatment of focal chondral lesion in the weight-bearing area of the femoral condyle by OTS system. We had a 30 patient with a 30 knee in a prospective clinical study has been performed between March 2017 to March 2019 in Menifee University Hospital. We had a selection criteria age between 15 and 45 years with a focal grade 3 or 4 unipolar lesion in the weight-bearing surface of the femoral condyle that are between 1 to 3 centimeters in size with minimal or absent degenerative changes in the surrounding articular cartilage. with a normal knee biomechanics alignment and stability. We're starting by arthroscopic examination for assessment of the defect site, size, depth, and the containment after debridement and ICRS classification. Evaluation of the quality of the donor area as well as overall status of the articular cartilage, and evaluation of any ligament or meniscal associated injury, and extraction of the loose bodies. We do all our cases by mini open technique by 3 to 4 centimeter along the medial and the lateral parapatellar sagittal incision, with the available commercial available knife for especially for OTS. Starting with the recipient side preparation, the recipient harvester is assembled and positioned perpendicular to the defect. Then the harvester is then impacted to the desired depth, usually not less than 15 millimeter. Then the harvester is removed by creating a bone stock by twisting fashion, and a graduated alignment rod is used to measure the recipient socket depth and the insertion angle of the graft. Then harvesting of the graft, the donor harvester is positioned perpendicular to the donor surface, and using a mallet, the donor harvester is impacted to the desired depth corresponding to the recipient socket. Then the plug is extracted by axial distraction of the harvester, rotating it 90-degree clockwise and 90-degree anti-clockwise. The depth of the core is referenced through the harvester window. So selection of the donor site, usually we use the periphery of the trochlea above the sulcus terminalis. Graft implantation, the beveled edge of the delivery tube is inserted perpendicular into the recipient socket, and the graft is advanced into its recipient socket. Final seating of the graft. The final seating of the graft is performed using a thumb to be in a line and flushed with the nearby cartilage. The thumb is hammered over graft and the nearby cartilage to avoid oversinking of the graft, like here. Repeating the same steps for each plug in a larger defect, and we may use a snowman technique or interlock the graft to decrease the interstitials, which is filled by fibrocartilage, and maximizing the hyaline cartilage surface. In a larger defect, the recipient socket should be prepared perpendicular to the surface in the central area, and increasing obliquity 10 to 15 degrees towards the periphery, respecting the congruity of the articular surface and matching the curvature of the femoral condyle. Once the graft are in place, flexion and extension movement are made to make sure that the graft is perfectly stable. The donor sockets may be filled with the bony plugs obtained from the receiver socket, and then closing the wound in layers. Post-operative evaluation. The patient followed up in outpatient clinics through the routine follow-up at 2 weeks, 6 weeks, 3 months, 6 months, and at 1 year as a routine part of monitoring and IKDC scoring, X-ray and MRI at 3 and 6 and at 1 year. Our rehabilitation protocol starting with immediate motion and then weight bearing for 2 to 4 weeks, then progressive weight bearing starting at 4 to 6 weeks, and the patient are typically withheld from sport activity from 3 to 6 months. Our results showing the predominance of male gender with affection of the medial femoral condyle in 90% of cases, and the right side in 60% of cases, with a mean size defect is 2.5 centimeter, ranged from 1.2 to 3 centimeter, with a duration of symptoms from 9 to 19 months. And the OCD is the most common cause of our cases in 80%, followed by degenerative lesions in 13% and traumatic just in 2 cases. Our results showing marked improvement in the post-operative subjective IKDC score, post-operatively for 86.9 at 12 months follow-up in comparison to the pre-operative one, which is 52.5. And the final objective IKDC show also highly statistically significant improvement in the post-operative objective IKDC in comparing to the pre-operative one. We had a negative correlation with the female sex, age, size of the lesion, body mass index, and the maximum size of the recipient sockets, and the positive correlation with the ICRS scoring of the nearby cartilage and the percent of coverage and the congruity. Complication, post-operative clicking, effusion, pain, and the tenderness at the harvest site. All of the above complications usually decreased and disappeared by 3rd month post-operative. This is a male patient, 20 years old, with a history of repeated trauma, with recurrent history of pain and catching along the last 9 months, infrequent attacks of locking and giving way. Subjective IKDC score was 49 pre-operative and objective grade 3. Grade C. X-ray and MRI showing a focal chondral defect in the medial femoral condyle occupying the whole weight-bearing area. Starting by diagnostic arthroscope, extraction of the loose body and assessment of the defect, and followed by mini arthrotomy and the preparation of the chondral defect and insertion of two plugs 10 millimeter. The IKDC score improved to 96.2 post-operatively. The last follow-up and the grade A objectively. X-ray and MRI showing the filling of the recipient defect and the congruency of the medial femoral condyle and the incorporation of the graft in the corresponding condyle. On second arthroscopy, second look arthroscopy has been done at 9 months later, showing a complete filling of the defect with a hyaline covered cartilage over the both plugs and fibrocartilage in interstitials between the two plugs. The patient achieved full range of motion post-operatively. Another case of male patient 25 years old with IKDC, subjective IKDC score 57.3 and the grade C objectively. X-ray and CT and MRI showing a defect occupying the whole medial femoral condyle in the weight-bearing area. MRI showing extension of the defect along the weight-bearing area. Starting with arthroscopy and followed by arthrotomy. Insertion of 3 plugs obtained from the lateral femoral condyle and the grafting of the donor site. The objective IKDC score improved to A and subjective improved to 95.1. X-ray showing restoration of the joint line and the incorporation of the graft in the corresponding condyle, and the MRI showing filling of the defect and the congruency of the femoral condyle. The patient restored a full range of motion and the last follow-up. So our limitation is the donor site morbidity, limited availability of the autograft, congruity of the joint is difficult to reproduce those multiple plugs. The dead space between the graft filled with fibrocartilage, and the question about lack of peripheral integration of the donor site and the recipient hyaline cartilage, different orientation, thickness, and the mechanical properties of the donor site and the recipient hyaline cartilage. Our conclusion, the patient selection is mandatory for successful treatment. Any comorbidities should be addressed or corrected before or concurrent with any cartilage repair procedure. The odds is safe, efficient, and cost-effective for treatment of focal chondral lesion. Graft transferred should be flushed radial and delivered gently. Maximum coverage and stability in a breastfed fashion should be obtained. This technique should be limited to the chondral defect less than 4 centimeters. Thank you so much.
Assalamu alaikum. First of all, I'd like to introduce my great thanks for the conference committee and the EGAA committee for accepting this paper. Dear chairmen and colleagues, I'm Ashraf Azab. I will introduce about the different viewing portals during femoral tunnel placement in primary ACL reconstruction. This is my disclosure. No doubt that graft placement aligned with the native ACL could affect the clinical outcome. And the accuracy of femoral tunnel placement depend on the proper footprint viewing and proper drilling technique. The femoral tunnel placement technique could be done using a different viewing portal. And there is a controversy exists between the anterior arthroscopy group and the posterior arthroscopy group. The anterior arthroscopy group or the viewing portal, anterior viewing portal, including the anterolateral portal, the anteromedial portal. The posterior viewing group is the posterolateral portal and the transeptal portal. And also there is a many drilling method which include the transtibial method, the tibial independent anteromedial portal or the accessory anteromedial portal, and outside in drilling method. The purpose of this study was to systematically review the risk, benefits, advantage, and disadvantage of the different viewing portal for creating the ACL femoral tunnel. By another way, comparing the anterior viewing group, including the anteromedial portal or anterolateral portal, in comparison to the posterior group, which is the posterolateral portal and the transeptal portal. We searched the PubMed of English language study between 1st of January 2000 and November 2019, using the following term: anterior cruciate ligament, femoral footprint, and portals. And we included any ACL femoral tunneling drilling methods which show the advantage or disadvantage of the anterior or posterior viewing group. Our selection criteria: in a study reporting risk, benefits, advantage or disadvantage of any ACL femoral tunnel drilling method using anterior or posterior portal for femoral footprint localization. Also, the reference of included articles were reviewed to identify potential study missed in the original search. Our outcome were the advantage and disadvantage of anterior viewing method or the posterior viewing method. This is the result from the original search. We found 289 articles published between 2000 and 2019. Zero duplicate paper as we searched only in PubMed. 155 citation excluded after reading the title and abstract, as they didn't follow our inclusion criteria. 184 study fulfilled the inclusion criteria and were included in the study. 119 of this study showed the advantage of the anteromedial portal, and 45 study compared the anteromedial or accessory anteromedial and transtibial drilling method viewing from anterolateral or anteromedial portal. Only 20 study discussed the posterior viewing portal, and 6 study compared the anterior arthroscopy group and the posterior arthroscopy viewing portal. The anterior arthroscopy group, including the anterolateral portal and the anteromedial portal with different drilling technique, transtibial or anteromedial or accessory anteromedial group, and outside-in drilling method. This is the anterolateral viewing portal and transtibial drilling method, which near to be obsolete today because the ACL graft tunnel often result in a non-anatomical vertical ACL graft. The anterolateral viewing portal also viewing from anterolateral portal and making our tunnel, our femoral drilling using anteromedial portal. Because of the obliquity of the viewing picture from the anterolateral portal, here as we can see, you have you cannot localize the femoral footprint accurately with the anterolateral viewing portal. Therefore, anteromedial viewing portal was introduced and using accessory anteromedial drilling method. Also, using the anteromedial viewing portal outside in drilling method could be used. The other group is the posterior arthroscopy viewing group with the posterolateral viewing portal and outside in drilling method. In order to do this technique, we have to do a posterolateral portal by introducing the arthroscope from the anteromedial portal and passing the arthroscope into the posterolateral compartment, palpating the soft tissue and using trans-elimination and making a posterolateral portal. Also, we have to use a 70-degree arthroscope, as the arthroscope is introduced just behind the lateral femoral condyle, just behind the ACL femoral footprint, so we have to use a 70-degree arthroscope. The other technique is using the transseptal viewing portal. This technique have many advantage of direct viewing or viewing of the direct insertion of the ACL. Also, it have the advantage of accuracy and reproducibility. In order to, this is outside-in drilling guide and drilling using a flip cutter. In order to making this technique, we have to use 3 portal. The posteromedial portal, which is made by introducing the arthroscope from the anterolateral portal, passing to the posteromedial compartment, and using the same technique, trans-elimination and palpating the soft point, and avoid any veins to avoid injury of the sartorial branch of the saphenous nerve. Then making the posteromedial portal. After making the posteromedial portal, the arthroscope, this is the precautions used to avoid injury of the sartorial branch of the saphenous nerve. You have to put the tourniquet proximal on the leg holder using trans-elimination and avoid the long saphenous vein course. We keep the nerve and the vein 10 millimeter posterior to the longitudinal incision. The posterolateral portal is made also by the same technique. The arthroscope is introduced from the anteromedial portal, passing to the posterolateral compartment and making the posterolateral portal. This is precautions. You should be away from the biceps muscle to avoid injury of the peroneal nerve. The last portal in this technique is the transseptal portal. The posterior septum is a barrier between the posteromedial compartment and the posterolateral compartment. In order to open both compartments, you have to make a small incision or a small portal in the posterior septum. In comparison, some studies make a comparison between the anterior and the posterior portal. Anne et al. In 2017 and Lee et al. In 2017 making a study comparison between the anterior and the posterior portals using a post-operative 3D CT evaluation by calculating the accuracy and reproducibility. The accuracy is represented by the distance from the anatomic tunnel center to the tunnel aperture center, and the reproducibility by how much scatter. This is a quadrant method and anatomic method. The accuracy by calculating the absolute difference. The difference was the least in the transseptal group. Therefore, this is the most accurate method, which was more accurate more than the posterolateral group and the anterior arthroscopy group. Also, the reproducibility is more, they found that the transseptal group are more reproducible than the posterolateral group and the anterior group because there is no much scatter in the transseptal group. In conclusion, the anterior arthroscopy viewing technique have the advantage of the familiarity and the good learning curve with less risk on posterior neurovascular structure and proven long-term outcome. Also, it have a disadvantage of risk of non-accurate femoral tunnel placement, less reproducibility, and sacrificing the native ACL remnant in order to localize the femoral footprint. The posterior arthroscopy group have the advantage of direct viewing of the femoral footprint, accuracy, and reproducibility. Also, it preserves the native ACL remnant. However, it has a many disadvantages like less popularity and technically demanding with low learning curve. In order to in order to make a posterolateral portal or a posterolateral portal viewing method, you have to use a 7-degree arthroscope, which is not common with all arthroscopic surgeons. Also, to have a risk on posterior neurovascular structure more than other technique. In conclusion, there is no one single viewing method established, which is a gold standard, safe, easy, remnant preserving, accurate, and reproducible method for femoral tunnel footprint localization. In addition, both anterior and posterior viewing methods show diverse and subjective advantages and disadvantages, risk and benefit. At the end, we need to say that you should do the technique what you know and avoid any technique you don't know before doing it. Learning the learning curve will increase. Thank you.
Any question for Dr. Ashraf, last speaker? Okay.
You said that there was no difference in whether you look anterior-medially, anterolaterally, or posteriorly transeptal as far as functional results or...
Yeah.
So is it worth the risk of neurovascular injury to go transeptal if the results show there's not that much difference whether you look
I
posterior-laterally or not.
I tried in this study to summarize the portal, the viewing portal used for.
No, I'm asking now that you looked at it, in your practice.
Yes.
When you are operating, do you think it's worth the risk of neurovascular injury?
Actually, if you are not familiar with transseptal portal or the posterior arthroscopy, you have to avoid, because there is a risk of neurovascular injury. But if you are familiar with the technique and you are skilled enough and you have a learning curve enough for this technique, you can do. In posterior transseptal portal, you can see the direct insertion of the ACL without any remnant shaving. The neurovascular supply of the native ACL remnant. In my practice, I tried as much as possible to preserve the native ACL remnant, and sometimes I put my graft as a sheath between the old ACL. However, if I am going from doing anterior arthroscopy, viewing from the anteromedial or either anteromedial or anterolateral portal, it's very difficult to localize the femoral tunnel. To visualize the femoral footprint, it's very difficult from anterior if you didn't shave well to see the femoral footprint. However, in posterior arthroscopy, especially transseptal portal, you don't need to shave any of this remnant. You can go directly to the insertion of the ACL from posterior. But if you are familiar with the technique, it's easier and the remnant preserving technique.
Thank you.
Other question? Now question for Dr. Soliman Hassan. Dr. Soliman. طيب. Any question for Dr. Mohamed Abulsoud? Right.
Thank you very much for the presentation you've given, but I'm not sure really if there is an evidence that high tibial osteotomy and unicompartmental arthroplasty would achieve a similar result. I'm not sure whether the selection criteria for the two surgical interventions are the same, or the population that we would consider high tibial osteotomy are similar to the population where we can consider unicompartment. So I'm not sure, why did you say high tibial osteotomy gives a similar result to a unicompartmental arthroplasty?
Thank you for a very nice question. This is for young age, but we speak about a 60 or 62 years old man. You can't say that both gives a comparable results. When you speak about one who doesn't have a varus knee, and we said in our selection criteria, should the patient has metaphyseal varus. If the patient does not have metaphyseal varus, is not a candidate for high tibial osteotomy. This is another point. Yeah, but very, very, very nice remark to clarify this point, that both inclusion criteria are not always the same. But if they have both criteria sharing in the same patient, okay, you can both either. Thank you very much.
Well, I'll stress the point that candidates for high tibial osteotomy are not those exactly who would need to have any compartmental arthroplasty. I would stress the point that high tibial osteotomy, the criteria for success are different. I mean, you need to have some joint space, you need to have some articular cartilage that you are going to preserve and maintain the function of the joint for a few years having done a high tibial osteotomy, while unicompartmental arthroplasty is a procedure to be performed for someone who has lost the articular cartilage, has bone on bone, which is not a good indication for high tibial osteotomy.
Yes, this what happened. I've shown this in the paper of Rio in 2018, and speaking about pagoda knee. You speak about pagoda knee when you don't have a joint space, and he has his research papers about this point exactly, and found no difference between both groups, especially in young age. Yeah, I support this. This is very nice, but I transmitted this point as a separate statement in the study of Rio, which has been published 2018. It was about this point which Professor Ayman speaks about. When you have pagoda knee, when you have a bone and bone, could you do high tibial osteotomy? The answer, what he concluded is yes. It's not a high contraindication, especially when you speak about a young age. Thank you very much.
My question.
Yes.
Okay.
Yes, sir.
Continue. Okay. Did you find any evidence based that top athlete with a varus knee and he got ACL you combined or you just do the ACL because he was top athlete and he's. I know. Did you find anything?
ده
like
للدكتور النحاس.
The paper, the two meta-analysis I put in this presentation does not mention the daily or activity level. Did not make a difference between the elite athletes and ordinary population.
These are cases you did, the osteotomy, you did?
I do osteotomies, yes. That's why I do this lecture.
And I saw some studies I think have shown the benefit of doing an arthroscopy before the HDO.
Yes.
Did this group have an arthroscopy before they did the HDO? Or in your practice, have you seen that it's beneficial to do arthroscopic procedure, do some cleanup if you need it, and then do the HDO?
Yes, thank you for this question. Actually, in my practice, I do this after I've learned this in my university, and when I go fellowship, I see all the surgeons do arthroscopy before high table osteotomy. But I found out the evidence. Even in my practice, it's very rare to find a patient without any knee pathology, because we speak about symptomatic varus. He lives all his time like this. Why came to you in this point? Unless he has a problem in his knee. This point it needs to be solved by arthroscopy. I think this is my point.
Thank you.
Thank you.
Thank you. Question for Dr. Nahas, Mohamed Nahas.
Which paper is that?
High table osteotomy with ACL reconstruction.
So when you do an HTO and you have the tibial tunnel for your ACL surgery, do you have to change is it difficult? Do you have to change?
Of the
Does it
blade?
yeah, because if you do, did you do transtibial ACL?
No, medial, accessory medial portal, not
Okay.
transtibial.
Okay. But did you find any problems with fixation on the tibia with when you do also the HCI?
Yes,
the
at
same
start, some technically demanded point in this area. From the start, the side of the blade just to be anterior to the side of the blade just to be posterior to the side of the tunnel. The number one. Number two, between the osteotomy side and the blade to avoid leakage or pull out or rupture of the tunnel during the interference screw fixation. Number one, the site of the osteotomy must be degree just distal to the site of the tunnel and posterior.
Let me ask you, so this is patients who are relatively young, you are doing the HTO just because they have varus or tibial slope abnormalities on their x-ray?
Yes.
So do you think, so it seems like a lot of surgery to do for a patient who has varus because probably they have varus in the other knee as well, and to do an osteotomy just for a normal ACL, I understand for revision cases, but do you think it's worth the complication, the additional surgery, the plate and everything like that just for an ACL with a little bit of tibial slope abnormality?
Yet at the start, some patient refused to do the combined surgery from the start.
Me too.
From the start. When you tell the patient you make ACL reconstruction, that's okay. And when the patient know he do high tibial osteotomy, maybe escape in the night.
Okay, okay.
Thank you.
Dr. Ayman, Mohammed.
I have a question for my colleague Dr. Hesham and Dr. Asem.
لسه الدكتور النحاس عاوز يسأله.
Dr. Hesham, yeah, you asked a question. You did many cases in combined ACL and extra-articular tenodesis. So can you define which patient could benefit from the combined procedure rather than simple ACL reconstruction?
6 o'clock would close. Okay. Another.
I just have one question. What's the difference between grade 1, grade 2, and grade 3 pivot shift?
It's the classification that was the classification was proposed by Larson that just a glide or a clung or a jerk. The third one is jerk. We have locking of the knee at the third one.
So I think for us, it's very difficult. I don't believe in classification systems like that because I think if he does it, you do it, it's probably going to be a little bit different. And I think my issue with the extra-articular tenodesis, and I did this many years ago. We used to put a screw and washer on the ITB band, and then we did an extra-articular procedure with the ACL. But as one of you showed, I think maybe it was you, stiffness, arthrofibrosis, and that's one of the issues with that procedure. And I think the biggest thing we don't have, and maybe it will help us in the future, is some, as you mentioned, an objective instrumentation of the pivot shift, because it's one of the things, if you are doing that surgery just because you think the pivot shift is 2 instead of 1 or 3 instead of 2, that, you know, I don't think it's the same decision that every other person would make. But yeah, good paper.
I ask about if you did a lot of cases in your study.
Yes,
so could you define which patient will benefit from combined ACL reconstruction and extra-articular tenodesis or ACL reconstruction alone?
In our series, we use only the pivot grade 2 and 3 in all patients, but we didn't found this is an absolute indication for anterolateral ligament or extra-articular tenodesis because our cases was recreational athlete. I think we should preserve this strategy for high demand needs or high professional athletes, not for recreational athletes. I don't think they benefit from the procedure, taking the risk of fibrosis and flexion deformity.
And who had the paper for the HTO after, and it said the OCD was the #1 reason for the HTO? Which paper was that?
Dr. Nahas, Mohamed Nahas.
That was you, right? Who had, did the HTO, and they said #1 reason for doing the HTO surgery, there was a 21-year-old patient, they said OCD lesion is the #1 reason. Oh, I'm sorry, for mosaicplasty, yes, for that surgery. So there was a 21-year-old patient, and did you see anything in the way the patient was treated before the surgery with an OCD that would make you treat those patients differently? For example, they were treated conservatively, or they did not have surgery, or maybe they should have had fixation of the OCD. Did you see anything in those patients before that would have made it maybe unnecessary to do your Oates procedure because the lesion was fixed when they were younger?
Before he answers, I want to add a small comment. If you see our conference, you see that we are up to the level in a lot of surgeries. In cartilage surgery exactly, we are so much lacking behind Europe and the United States. Cartilage surgery is very, very expensive, and we have no tools to do cartilage surgery. We don't have good labs.
No, I know. I'm just asking about an Oates procedure.
Yes.
In a 16-year-old patient. So your patient was 21.
No, his patient,
the OC,
yes.
okay? Yeah. Did you see something in the records, how the patient was treated, that makes you think maybe if this patient would have had earlier intervention, a fixation, a screw in the OCD lesion, maybe the lesion does not become loose? Did you see anything to learn from that?
All of them came to us in a late time.
After
12 months, most of them.
Okay.
If you see the crater or the defect, all of them usually have a sclerosis, and the fragment
so old,
usually devitalized or separated. They came to us after a long period of locking and catching from the loose balls.
What would you do with that patient if you saw them when they were 16 years old with catching?
Earlier,
yeah.
We go for fixation.
With what? How?
We go for fixation by biodegradable pins or Herbert screws if it is sizable and has a subchondral bone enough to catch it. Or we used mosaic plasty as a plugs, like ballet technique. This is the methods we have do in such like these cases.
Yeah, I used to use the bio pins. I don't like it so much because they create some lysis, but I like to screw. And I go in about 4 months after surgery and I take the screw out. I look at my lesion and I take the screw out.
Depends on the subchondral bone. If it is sizable enough,
yeah,
and had a good subchondral bone, we go for a screw.
Yeah,
it has a good purchase and adequate fixation.
آخر سؤال دكتور سليمان. Yes, the last question. I have recognized that some of your patients is a weight-bearing area. You know that the osteochondritis is the lateral wall of medial femoral condyle.
Usually occupying the lateral part of the medial femoral
yes.
condyle. Yes.
Did you suggest that some of your cases may be a SPONC, osteonecrosis medial femoral condyle? Because you didn't show all your cases, you show only 3.
In SONC, the MRI usually show bone marrow edema extending beyond the lesion. Most of them well-defined, and they have a well-defined crater. Many of them came to us earlier and go for fixation if it is stable. But on all our cases, they have no history of trauma to exclude the trauma. They have insidious onset. They have no bone marrow edema beyond the lesion.
Okay, thank you. Thank you.
Thank you so much.
Thank you very much for all people, and I hope to see you again in the next Congress, inshallah.
I'm really thankful for everyone who has stayed until 5.